Well, welcome everybody. It's really exciting to see so many people here tonight. I come from a background in primary care, so it wasn't that many years ago that I was in my scheduled 7 minutes with my patient, desperately trying to convince them that the Wawa hoagie they ate for lunch was causing some GI symptoms, and how absurd that could possibly be. So it's so exciting to be in a room full of people that recognize the connection of how we feed ourselves and how our body responds, and are interested and engaged and willing to take time on a cold, almost winter night to come out and learn more. So really kudos to you guys for taking your health in your own hands. It is. Yep. So Anne-Marie has so expertly done the last couple talks, but when Dr. Tetlow and her were discussing doing SIBO, I couldn't help but jump in. I see a lot of familiar faces who are patients of mine or the practice, and they know how fascinating I find the gut. So I couldn't stay away tonight. And here at PIM, both Anne-Marie, Dr. Tetlow, and I, we fully believe that your gut health is foundational to wellness. So let's get started learning a little more. So this is our agenda for tonight, and I realize we may have people that are truly experts on their gut health, and some people that this might be new, so I'll try and appeal to everybody. We want to talk a little bit review about the importance of the gut and our microbiome. We're going to add a case presentation into tonight. Her name's Jane, so we'll check in with Jane throughout and kind of follow her journey. We're going to talk about what SIBO is, or small intestinal bacterial overgrowth, what is a leaky gut, how you test for it, how you treat it, so that you walk away. And I really want to spend the most of our time talking about how you treat it, so that you have some applicable things to walk away with tonight. So the importance of a healthy gut. So not only do we absorb and digest our nutrients that act as fuel for our body in our GI tract, but we also act as our second brain. More neurotransmitters, things like serotonin, norepinephrine, epinephrine, things that make us feel good and help us sleep, they are produced here than in our brain. Our gut is also encoded with a nervous system. So many of you have felt this connection. We're feeling nervous. We feel our gut rumbling. Feeling it now. But we often don't realize that our gut communicates with our brain. It's bidirectional. So it's pretty neat that our thoughts can affect our GI system, but our GI system can affect our mood and our thoughts. It also houses our immune system. 75% of our immune system actually lives in our GI tract. It's the gatekeeper of inflammation. And the more we learn about chronic inflammation, it's pretty much associated with every chronic disease out there, from heart disease to diabetes to autoimmune conditions. Plays a big role in metabolism and weight management, and it does so in several ways. 20% of thyroid hormone is converted from inactive form T4 to active form T3 in our gut. So 20% more thyroid hormone that regulates metabolism. I think we'd all like that little boost. It also, the composition of the bacteria in our gut, the good guys that are our friends in our large intestines, they govern weight management. There's been studies that show particular ratios of certain phylums are associated with obesity. So this is something that actually the microbes in our gut can play a role. Also plays a key role in processing and eliminating hormones. So our body uses hormones. They are converted to a less favorable form, and then they are put in our GI tract to be eliminated. If this is processes, if we're not eliminating, which happens a lot with people that have constipation, or if we have high levels of certain enzymes like beta-glucuronidase and we're reabsorbing these hormones, it can definitely affect our hormone systems in our body. So really, it's not just absorbing and digesting nutrients. Our gut plays a huge role in our overall health. So what is a microbiome? We're learning more and more about what this is every day. We used to think that all bacteria and viruses and parasites were bad for us and we should kill them with antibiotics. But we're now learning that they're our friends and we live in a symbiotic relationship. So we are full of microbes. They are on our skin, in our nose, primarily in the largest numbers in our large intestine and colon. And this is where they really interface with our immune system. So just a couple fun trivia facts here. We carry around 6 pounds of microbes, which is 10 to 100 trillion. And we have more DNA from bacteria in our bodies than we do our own human DNA, which I always find interesting. We are seeded with this microbiome as we pass through the birth canal during birth. And then that is influenced through whether we're breastfed or not, through our diet, through our environmental exposures, through our stress as children, all the way up through adulthood. Antibiotic use, NSAIDs all affect someone's individual microbiome. And I look at microbiomes through stool studies all day, because they're my favorite test, and more about that later. And I can tell you not one looks the same. It's so unique to the individual. It's kind of as unique as a thumbprint. So here's Jane. I'm hoping that we all relate a little with Jane. I certainly did. Actually, when I was making this PowerPoint, I was, busy mother of 3 children, and I was looking for a picture, and my husband's sitting next to me, and he's like, "You don't have a picture of you could put up there?" And I was like, "Nope. We're going to use this Jane." So Jane is 43. She's a busy mother of 3 children. She works full time, has a stressful job. I don't. I'm not saying I do. Took it. No, I only have 2. Took antibiotics for acne for several years in her 20s, had a bad case of food poisoning 3 years ago, and she eats a standard American diet, which pretty much means a lot of processed foods, a lot of takeout, pretty much a lot of real food. She started with irritable bowel symptoms in the last 3 years. She feels 6 months pregnant after meals. She has intermittent diarrhea, constipation, cramping, fatigue, and then acne rosacea, which is acne that's primarily through here that kind of get a facial flush. So she presented to my office with these symptoms, and she was referred from a colleague. So when I met Jane, the first thing I thought of is what's going on in her gut. Obviously, she's having GI symptoms, so that's a good place to start. But when I see any sort of skin condition, I also immediately think about our gut health, because our skin is part of our immune system. And oftentimes when there's imbalance in our gut microbiome, it can manifest as skin issues. So the first thing I thought of was, does Jane have intestinal permeability or leaky gut? And could SIBO be at play here? So let's talk a little bit about what each one of those are. So intestinal permeability is the scientific or fancy name for leaky gut. And this theory's been around for quite a while. It hasn't been scientifically accepted until the last probably 20 years or so. Now, however, if you go to PubMed and search intestinal permeability, you will see tens of thousands of scientific literature associating this condition with everything from irritable bowel symptoms to autoimmune disease. So what is it? So our gut lining, which lines our gut from our mouth all the way out, is only 1 cell layer thick. And the tissue it is epithelium, which is the same as skin tissue. And all these cells are held together, kind of like this, with tight junctions. And the role of this is to act as a barrier, so that food that has been digested and broken down and is ready to enter our bloodstream, which is right here, to be used, can pass through. And food that hasn't been broken down, or toxins, or things that we're exposed to our environment, can't pass through because they're a barrier, so that they can't get into our bloodstream here. But what can happen, and there are many causes of this, from frequent antibiotic use, to NSAID use, to exposure to viruses, to standard American diet, to gluten, that can all affect these tight junctions, is that they become loose. And now it's a sieve. And now things that are coming through our GI tract here that weren't meant to get into our bloodstream are getting into our bloodstream. And what's in our bloodstream floating around is our immune cells, because they're our soldiers, they're surveilling. And if they're starting to get provoked, they get on high alert. And then it causes this kind of trickle effect where our immune system starts behaving inappropriately and targeting our own organs, sometimes, as it happens in autoimmune disease, and creating armies against them. Or creates food sensitivities or allergies, so we're unable to tolerate things that we should be able to tolerate in our gut. So it's really a breakdown of these tight junctions. And the things that are holding this together is a molecule called zonulin. And zonulin is what kind of keeps these tight junctions intact. This was discovered by Dr. Fasano, who's a world-class researcher on gluten sensitivities and allergies, and he's the first to discover zonulin, which is now widely accepted. So how do you know if you have intestinal permeability? How does it present? Really, it's incredibly common, and you don't have to have GI symptoms. I think the most common thing I actually think of in the clinic, and Georgia, you can speak to this, is whenever I see someone with autoimmune disease, I assume they have a leaky gut, or I assume that they have intestinal permeability, because something is triggering their immune system to behave inappropriately. And not all the time it's this, but a lot of times it is. Any questions on what leaky gut is or what intestinal permeability is? All right. It was this that helped, wasn't it? I just keep doing this. Everyone's like, yeah, I got it. Okay, so what is SIBO? Now, this has become a little bit of a fascination of mine in the last 2 years. One, from a personal experience with my mother, but also from working with patients. It has been incredibly rewarding and incredibly frustrating, as any SIBO patient could tell you. So what is SIBO? It's small intestinal bacterial overgrowth. So we think about our GI tract, all those microbes that we talked about earlier, they're in our large intestine, and we want them to stay in our large intestine. Our small intestine, which is right below our stomach and between our stomach and our large intestine, is actually relatively low in bacteria. And it's supposed to be. We have multiple physiological functions that keep this low in bacteria. Things like gastric acid to kill bacteria in our stomach. Things like bile secretion. Things like motility and movement, which help push things through. And we have all these functions so that our small intestine can do its job, which is primarily to absorb. So when we have high or inappropriate levels of bacteria in this area, it inhibits absorption, but also causes inflammation. And what SIBO is an overgrowth or too much bacteria in the small intestine. It's not pathogenic bacteria. It's commensal bacteria. It's bacteria that's supposed to be in your large intestine, but it's in the wrong place. And that causes a lot of issues. So there are two main types that you'll hear or that we'll talk about tonight, hydrogen and methane. And these refer to the gases that are produced by the bacteria and archaea. Hydrogen can be a range of different bacteria. The most common are Enterococcus, Proteus, Klebsiella, Staph, and Strep are the most common. Methane is produced by archaea, which archaea are those creepy, I don't mean to say creepy, those bacteria that live in like the hot springs that can like survive any temperature, really old, they probably outlive, they're pretty intense. And it's Methobrevibacter smithii is the archaea that is associated with methane bacteria. To make things more complicated, it doesn't have to be a bacteria or an archaea. We're also starting to find that about 20% of patients that have SIBO also have SIFO, which means small intestinal fungal overgrowth. We love our acronyms. And there's no test for this, so that makes it even more difficult. There's also been suggestion that another form of gas called hydrogen sulfide could be at play, and again, no test for this. So these are mostly symptom-based in the clinic. So as we talked about, SIBO can affect both absorption and inflammation. So how does it present? Typical, you see GI symptoms. There's a big correlation between IBS, irritable bowel syndrome, with SIBO. Actually, Dr. Pimentel, who's kind of the godfather of SIBO, if you will, he does all the research out at Cedars-Sinai. He found up to 75% of patients that have IBS have SIBO. So intermittent diarrhea and constipation, nausea, abdominal pain, and bloating. Bloating is a big one. Are an IBS forward presentation. But just like intestinal permeability, you don't have to have GI symptoms to have SIBO. And as you can see by my illustration here, these are all other things that are associated with small intestinal bacterial overgrowth. So you think of the typical GI symptoms, but the other thing I think of is the skin conditions, acne, rosacea, and there's been clinical trials on each of these conditions and the association with SIBO. And a really great resource is SIBOinfo.com. It's Dr. Seebecker's website, and she actually lists all the associated conditions and links to all the clinical trials. which I think can be invaluable. So I see acne rosacea, depression, weight loss. I see weight gain as well, vomiting, fatigue, joint pain, malnutrition. So if we think about the primary role of the small intestine, it's absorption. So if you have overgrowth there, you are not absorbing. So oftentimes you can see malnutrition and nutrient deficiencies. The most common ones I see with SIBO are B12. The B12 molecule is quite large. It's hard to absorb regardless. So you add the additional factor of having inflammation and bacteria where it's not supposed to be. It makes B12 really hard to absorb. Iron. I see a lot of iron deficiency with SIBO. I see a lot of vitamin D deficiency and other fat-soluble vitamins like A, E, and K. Those are the most common things I see. Are there any other vitamins you see low with SIBO?
I would say B vitamins in general.
Yes.
Because B vitamins are primarily absorbed in the small intestine, but definitely fat-soluble vitamins. I think you covered it, Lauren.
Okay. Right. So back to Jane. So these are the tests that we ran on Jane. I think one of the really wonderful things about integrative medicine is we have access to these advanced testing. Although you can get a SIBO breath test at your GI doctor, Penn and Jefferson both have the machines down at the hospital, and you can go and actually do the testing there. But we have kits you can do at home, which are validated and a lot easier. A stool study, the poop test. And then I also usually run LabCorp and Quest labs to look at nutrient status, to look at inflammation, and to check in on hormone dysfunction. So this is what we ran on Jane. So let's go over some of those tests. So this is the breath test. This is a pretty amazing concept. So when we think about that bacteria that's growing in the small intestine, it is fed by what we eat, primarily things like fermentable carbohydrates are its favorite food source. And when it eats these, or when you eat these, it creates gas. It produces gas, primarily hydrogen and methane. So the idea of the test is you take a baseline exhalation, and then you consume lactulose or glucose, and they're gross. And then you blow exhalation again for 120 to 180 minutes. And it looks for a rise in methane and hydrogen. And that would symbolize that you have too much bacteria in this area because they're producing all this gas in response to the lactulose or glucose. So it's a pretty annoying test to do because it's, a 3-hour test. You have to fast beforehand. You have to follow a special diet the day before, which is pretty much rice and chicken. It's like a no-fiber diet. But it's important because we're able to see where your levels are and also what type of gas is showing, and also where you're showing a peak in gas. So there are 2 types of solutions you can use, lactulose or glucose. We primarily use lactulose in our clinic unless someone has an allergy, which people have had to lactulose. And that's because lactulose is more sensitive. Glucose really is good at detecting SIBO very close to the stomach, the first part of the small intestine, but then it's absorbed. So it can miss a lot of people because your small intestine is quite long. And lactulose catches the whole small intestine. So we prefer to use the lactulose solution. We're looking for a change in gas, and gas is measured in parts per million. So we're looking for a change of 20 parts per million in hydrogen, which would be considered positive. And then we're looking for a 10 parts per million value for methane at any point throughout the test. So methane doesn't have to rise. If you start the test and your methane's 50, you're positive. And those are new guidelines. And like I said before, there's no test for SIBO or hydrogen sulfide. There are some things that I'll see on the study that suggest that, but they haven't been, scientifically validated. Any questions about the test? Yeah.
Well, not about the test. I
Sure.
have a general question.
Yeah.
You said it's SIBO,
Yes.
fungal. Is
Yeah.
that the same thing as candida?
No.
Okay.
So yes and no. So candida could be the fungus that's overgrowing, but it's not systemic candida. It's candida in your small intestine.
It's about the leaky gut.
Sure.
Can you actually repair that, or is it
Yes.
once you have leaky gut?
Yeah. Great question. And we're going to talk about exactly what we can do to repair it. But our gut lining regenerates every like 3 to 5 weeks. 3 to 3.
It's good for 7 days.
Yeah. So there's a lot of room for lifestyle things that can help repair that. And we use a 5R approach. And absolutely, yes, can be repaired.
And that's a big part of the presentation is to give you some of those tools.
Yeah. Our body has a remarkable ability to heal if we give it what it needs, which is what integrative medicine is. Yeah. Yes, back row. Yes. So it's not a perfect test, but it's the best we have. The question was, can you give false positive and false negatives? Yes. It's not a perfect test, but it's the best we have. Some of the things that I look for is a peak at the very end. Like if I start to see a peak at the end where it's not quite 20 parts per million, if that person has really low transit and they're just not moving very quickly through their small intestines, that can be a sign to me that maybe they have SIBO and it just we didn't give enough time for it to peak. So that's a false negative that I see sometimes. I am also very liberal with methane gas. There's some experts out there, and I kind of start to fall in this camp that anything greater than 3 to 5 parts per million methane, it's worth treating. Some hydrogen is normal in your small intestine, methane's really not. So oftentimes if I have a patient that has a lower level of methane, I will consider treating them if their symptoms warrant it. Also, too, if I have a flat line test where the line just goes straight across zeros all the way across, and the patient has like foul-smelling gas, kind of rotten egg, sulfur smelling, I will consider hydrogen sulfide because that's typically how it presents on a breath test. Sure.
I think there's another issue with false positives and false negatives, which is that a lot of providers do not know how to interpret this test.
Yeah.
And that even though they have the facility and they have the ability to order the test and to review the results, just this morning, Anne Marie, who's one of our star providers, before she was trained in functional medicine and integrative medicine, she was concerned about her child having SIBO. And she brought her child to an integrative physician who did one of these tests and said the test was negative. And the first methane value was 25 parts per million, which is way, way above the 10 parts per million, which would be a positive test. And sometimes people are even going 3 to 5 parts, like Lauren said. So a big issue is you can order the test and you can have the facility and you can be there sitting in front of your provider, but you also need to know how to interpret it accurately. That's
Is that
the
all regulated now? The interpretation, is that like all regulated?
There's
art of medicine is not regulated.
there are guidelines.
You can get a certificate.
There are guidelines out there. I don't know if a lot of providers are up to date. Yeah,
Many are not up to date.
and it's hard to stay up to date. Especially in primary care and in the traditional system, you don't have the time or the and I would call it a luxury to do the research that I think we've been able to do. Amy. Yep. Yeah. Yeah. So I think there's a question about gut motility and how it affects the test. I think gut motility does affect the test, particularly if your transit time is really slow. You're going to have higher levels of methane if you're constipated before the test because you're not moving through. Things are building up. However, gut motility is also something that can cause SIBO or being an underlying issue. So when we talk about treatment, addressing motility is on it. So it's not like it's not being addressed regardless. But I think that we need to know more. SIBO is a relatively new clinical topic, and the more research is coming out every day. But we're working with the best information we have.
And for many years, it was never
Yes.
considered possible that you could have a part of your intestine which had too much bacteria, which is kind of unbelievable.
Yeah.
That you could have a part of your intestine that it wasn't possible to have a bacterial imbalance in a part of your intestine.
Yeah. Dr. Mullen, who does a lot of research with SIBO, he's kind of a renowned integrative GI doc at Hopkins. He taught our GI module in our fellowship, but he also taught at the last IFM conference, functional medicine conference on GI, and he said people laughed at him. He got laughed out of rooms talking about SIBO. And now everyone's calling, what do I do about this patient? Can I send this patient to you? So he's definitely ahead of the curve. So this is my other favorite test. This is the poop test. You're going to have to stop me because I could talk all day about it. So I use this test to look for intestinal permeability. There are other tests out there, but this is the one that we use primarily in our clinic because it gives us the most information. And some of the markers that I look at specifically for intestinal permeability are this little inflammation category here. See the flame? Looks ominous, right? EPX and fecal secretory IgA, calprotectin's the other marker it looks for. When they're elevated, it tells me there's inflammation in the gut. Fecal secretory IgA in particular is the marker that I really look for to show me there's intestinal permeability. This makes, fecal secretory IgA makes the mucus lining of our gut. So it acts as a protection to our gut lining. And when the levels are high, it's saying that our body is trying its best to repair this lining, that it's making mucus and mucus and mucus, and it needs some support. So that's the marker I use to look for leaky gut. This test also gives me a lot of information about SIBO too. I often see poorly digested fats and proteins with SIBO. That makes sense if you're not absorbing. I often see parasites with SIBO. There's a big correlation there. And if you don't treat the parasites, it's very hard to treat the SIBO. And then I often see bacterial overgrowth in the large intestine as well. And then the one page in this test that does a DNA PCR, so it looks at all the different phylums. I'll see on a SIBO patient, they have high levels of everything. And I'll be like, ooh, we need to test you for SIBO. So that's another way I look for it. So that's this. See, I did pretty good. That was only like 2 minutes on the stool study. Feeling pretty good about myself there. So this is Jane. This is what we found on hers. We saw an increase of 60 parts per million of hydrogen, which is a pretty decent increase, indicating SIBO. She had high fecal secretory IgA, which indicated a leaky gut. We saw fat malabsorption on the stool study, meaning that all her fat was coming out in her poop, which it shouldn't. You should be absorbing it. And then we saw low levels of B12, iron, and vitamin D on her blood work. So how do we help Jane? Or first off, why does Jane have SIBO? I think the why is important. So these are causes and contributing factors. These are specific to SIBO, but they all relate to intestinal permeability and leaky gut too. So there are three main issues, if I want to group them together, that contribute to SIBO. The first is a deficiency of the migrating motor complex. So this is a little anatomical for everyone here, but if you see this nice man's stomach, our small intestine has this migrating motor complex, and its role is to squeeze the small intestine so that anything that's left over there from meals is pushes out and clears into the large intestine. So it does the same function that our large intestine does, where it moves everything through in the small intestine. And it's called, I'll call it the MMC because that's easier to say. So it controls peristalsis of the small intestine. So what can happen, that can be a cause of SIBO, is there can be a deficiency. Something can happen to the MMC where it's not functioning. So that you eat food, all our food, most of our food has some level of microbes on it, and it doesn't get pushed out, and it sits. And then we feed more food, and it feeds that, and it kind of causes this cycle. So what can affect this? Believe it or not, the number one cause of SIBO is actually a post-infectious gastroenteritis. So food poisoning and a GI bug. So what happens is when we're exposed to these gram-negative bacteria, things like E. coli and Shigella and Salmonella, is they cause cytotoxins. Those are things that are released by those microbes, and those cytotoxins attack the nerves in the MMC. And when these nerves are inhibited, they don't contract as well. So that's the number one cause is the food poisoning and gastroenteritis. Other viruses can affect this as well. A common one is Lyme. Lyme loves nerves. I think most people know one of the common symptoms of Lyme disease is nerve pain. So that can also affect the nerves in our small intestine. Hypothyroidism can affect nerves. If anyone's a patient of our practice, we always check reflexes, and that gives us an idea of hypothyroid tone, which, our thyroid affects everything. It governs every metabolism of every cell in our body, so it can affect the nerves. Sympathetic dominance, so this is a fancy word of saying stress, which we all feel. That can affect the nerves. Drugs, things like opiates and antibiotics, they too. And then neuropathies, the most common being diabetic neuropathies. We think about diabetes affecting the nerves in our legs, in our eyes, but they're not specific to those. They can affect the nerves in our small intestine. So the first thing is that flushing motion is not happening, or it's not happening well. The second cause we think of is structural abnormalities. So if we've had surgery, whether it's laparoscopic or not, in our abdomen, we create adhesions or scar tissue, sometimes strictures, and this can actually inhibit the contracting. So it's not so much the nerves not working, it just literally is a barrier to the contraction. And this can happen with C-sections, appendectomies, gallbladder removers, hysterectomies, or gastric bypass. They all can affect. So any abdominal surgery for me is one of those things that I think of, okay, how is that affecting our GI tract? And the third is altered function. So if bacteria is not killed in our stomach or our small intestines, it can continue to grow in an area that's not supposed to. So gastric pH or gastric acidity is one of the most important barriers we have. Unfortunately, PPIs, things like Nexium and Zantac, are widely available and prescribed a lot. And what they do is they turn off gastric pumps. So not only does this affect how our body can process the food and absorb nutrients like magnesium and important things for bone health, but now it's that level of protection is not there. Other things that can affect it is bile. So if you've had your gallbladder out, or your liver is sluggish, or your pancreas is inflamed, all those things can affect bile. And if you're not using the bile to help break things down and push things through, that can affect it. And then, like I said, the medications also play a role. And all these things can also affect intestinal permeability and leaky gut as well. So let's really dig into the meat of it. What do we do? So there are two phases in SIBO treatment. Phase 1 is to treat the overgrowth, pretty much decrease the bugs. Phase 2 is to prevent and repair. Sometimes people call this the kill phase. I don't like that. It's a little violent. Plus, I think sometimes you're having some bacteria in your small intestine. It's not a sterile environment. So there are three main elements to treating overgrowth: prescription antibiotics, herbal antimicrobials, and an elemental diet. So prescription antibiotics, the primary antibiotic used is called Xifaxan or rifaximin. It's a 2-week course, 3 times a day. It has about a 64% cure rate for SIBO. It works primarily on hydrogen. It doesn't do a whole lot for methane, dominant SIBO. It is well tolerated. And in terms of antibiotics, it's a good one, if I can say that, because it works at a certain pH, and that pH is at the small intestine. So when it gets to the large intestine, it doesn't kill off all your good bacteria because it's inactive. But again, it can be very expensive if your insurance doesn't cover it, and it really only works for hydrogen. Some other SIBO experts out there recommend using it in combination with things like neomycin and flagyl, which are pretty heavy-duty antibiotics. I typically steer away from that. I know Dr. Tetlow and Anne-Marie try to as well. These can affect your large intestine and have an increased risk of things like C. diff. Neomycin can cause ototoxicity or hearing loss. And I haven't seen the data to show that they're that much more effective. But I do use Xifaxan on its own, particularly with hydrogen patients, and most people do pretty well with it. My favorite method is herbal antimicrobials. So Dr. Mullen, who I referenced before at Hopkins, actually did a clinical trial comparing Xifaxan to herbal antimicrobials, and they were equal, if not better, in terms of eradication. The benefit of the herbs is that it's not specific to just bacteria. It also can treat yeast. And with herbs, they have dual functions. You know, some things like peppermint is very soothing to your gut. So not only is it decreasing bacteria and acting as an antibiotic and antifungal, but it also helps soothe the gut. So I think there's more promise with herbal protocols, and I certainly see with my patients better outcomes.
Now, is that also only for hydrogen, or is that also for methane?
Great question. So I use herbs for hydrogen and methane. So these are some examples of herbs: berberine, neem. This is a berberine plant over here. Neem, oregano oil, peppermint, allicin, which is high potency garlic. I also use something called Atrantil, which is a combination product that has some peppermint and some horse chestnut, and that's really good for methane dominant SIBO. So as most of my patients know, I don't do a protocol. It's not, okay, you have SIBO, it's hydrogen, here's what you do. It's very specific to the individual. If someone is really sensitive and to foods and to supplements, I will start one herb at a time. And I'll do a single herb and I'll get that to the highest dose, and then I'll add usually 2 at a time. And I usually do 4 to 6 weeks. If someone is pretty good with tolerating things, I really like a product called Candibacter AR and BR, and I use those 2 products in combination. They were used in the clinical trial that Dr. Mullen did, so it's evidence-based. And the BR is berberine, and the AR is a combination of oregano, lemon balm, and thyme. And I usually do that for 4 to 6 weeks. The other herb that I really like specifically for methane SIBO is allicin, and that's really what has the most clinical efficacy so far. And specifically, you really want allicin. I like the product Alamed because, one, you don't smell like an Italian restaurant after you consume it, which patients are very thankful for, and also it's the highest potency. And that's what I found in the clinic to be most effective for methane. But methane's still tricky. I will be the first to say that I am still learning with methane. I think we all are as a community. Sure.
Would this be good for the fungal?
Yes. All of these herbs also have antifungal properties. Yep. Go ahead.
Is Xifaxan only for kids or adults over 18?
No, they use it in children as well. Mm-hmm. It's a different dosing, but yes. Mm-hmm. The elemental diet. So this is actually probably the most effective in terms of what the clinical data has shown. Form of treatment, about 80 to 85% in eradicating SIBO, but it is not pleasant. It is a 2-week liquid-only diet. So the idea is we are starving the bacteria. That's the principle by how it works. So during this 2-week, you don't consume anything besides a medicinal food. We use something, it's a product by Integrative Therapeutics. It's called Physician's Elemental Diet. It's not cheap either. It's a little bit of an investment, but you won't be buying any food for 2 weeks. And if you shop at Whole Foods, that may come out on top there. And what it's food. It's the nutrients you need to survive on the most broken down basic level. So it's pretty much pure amino acids and sugar, and so that it's rapidly absorbed and it sustains you, but you're not eating anything for 2 weeks. A lot of my patients that have done it actually enjoy it because if you've ever had constant bloating or constipation or abdominal pain, anything that helps is doable. And a lot of my SIBO patients say that they feel best first thing in the morning before they eat anything. I see a lot of heads shaking there. So it can be helpful. And the other piece is some patients that have dealt with this for a long time, they struggle with what to eat. What am I going to eat? It's a chore figuring out what I'm going to eat. What can I tolerate? And sometimes it's a break to say, okay, I'm just drinking this really gross drink 3 times a day, and I don't have to think about it. So I've had it go both ways. So what I usually do is I had patients do a 14 days. I have them meet with our nutritionist before and close to the end, sometimes 2 or 3 times. She has to calculate the amount of calories you need, so how much powder you would need. She guides you through how to drink it. And then on day 15, I retest and see where your levels are at. And the test usually comes back within like 3 to 4 days. And I call the company and I'm like, where's my test? And in that time, that patient is transitioning to a partial elemental and then starts to gradually have more foods. So that's the protocol we've used in the office, and that's worked out pretty well. One thing that I will say about the elemental diet is that if a patient has known candida overgrowth, like they have frequent yeast infections or their stool study showed yeast overgrowth, I typically will put them on an antifungal while they're doing the elemental diet just to protect them about any potential yeast overgrowth because it has a lot of sugar in it. Mm-hmm.
The elemental, well, two questions. The
Yeah.
elemental diet work for both hydrogen as well as methane, and also, is that something that is better for your good bugs than a course of antibiotics, whether herbal or prescription?
Great question. So it does work for both hydrogen and methane. Methane is still more difficult. And you don't want to be on an elemental diet long term or you don't want to also be on herbals forever, and you don't want to be on antibiotics forever. You also don't want to be on a low FODMAP diet forever because none of them are particularly wonderful for your large intestine, which loves fiber and loves probiotic fermented foods. I will say the elemental diet has been studied in things like IBD, Crohn's ulcerative colitis, and can be helpful at achieving remission. So yes, there's some benefit to the large intestine as well with the elemental diet. Other things I have on here these are some things that I think of with my tough cases, where I've tried the herbs, we've tried the antibiotics. I'm still convincing them about the elemental diet sometimes, but sometimes I'll add in a couple other elements that have been shown clinically and research-wise to be helpful. One of them is a biofilm disruptor. So bacteria in our body, not just in our small intestine, in our large intestine, on our skin, everywhere, they like us. We're nice hosts. We keep them warm. We feed them. And they create mucus coatings over themselves to protect them from antibiotics, from antimicrobials. So what I'll often do is put someone on an agent that actually pokes holes in this mucosal lining so that the herbs or the antibiotics can actually go in and do their job and decrease the level of bacteria. So my favorite one is NAC, or N-acetylcysteine, which is an amino acid. It does a really good job at this, but it also has lots of other benefits like liver support and detoxification support and hormone health and all those things. So it's something that everyone can kind of benefit from. Another one I use is Interphase, which is a combination of enzymes. Hi.
I was just wondering, what is the ideal time to retest if you were doing one of the prescriptions or
Yep. Great. So the question was, when do you repeat testing if you're not doing the elemental diet? So that varies from patient to patient. I usually start with a protocol, and I have them check in about, if it's an herbal protocol after 6 weeks. Do you feel any better? How much better? If they say, I feel 50% better but not there, I say, why don't we try another round of treatment before we retest? Just because I want to be mindful of resources. Some people want to test right away. I totally get that. I would love to have the data and retest each time, but it's about $200 to get tested. And we receive no benefit from testing. You deal directly with the company. So that usually after 2 rounds of treatment, I want to check in and see where we're at. But I would absolutely do it sooner if the patient is willing.
Similarly, would you do it the day after the treatment stops? Or
Yep. You want to do it within a week. Mm-hmm. Within a week. No. The question was, should you have 0 symptoms or be 100% improved when you test? No. I think even if your test is negative, it oftentimes takes a little bit of time to regain the balance and repair in both your small and large intestines. So I don't expect patients to come and be like, I'm 100, that'd be great. But if they're getting close to, 70, 80%, then I'm like, let's test, let's see where we're at. Because we also don't want to keep attacking something that's not there. We want to make sure that we're addressing what's really going on. Other things that as kind of in my toolkit, one is body work. So there's a huge gut-brain connection. I particularly like this for patients that have had abdominal surgery because helping to break up scar tissue and adhesions really helps with gastric motility. Also with patients that have constipation, learning how to do visceral massage and having a visceral massage by a trained practitioner can help regulate bowel movements and stimulate a bowel movement. There are certain, it's called the barrel method, and there's a website you can look up and you can search providers in this area, and I will often refer patients to providers to have experienced that and then kind of learn how to do it themselves. It's called visceral massage. And the massage therapists are usually who train it. Sometimes there's really good physical therapists that are trained as well, but it's typically a massage therapist. And then probiotics. And anyone that's done any research with SIBO has probably heard both sides of the aisle here. Some people say, yes, probiotics, absolutely. Some people are like, no, probiotics. And I kind of fall in the middle, and I think that's where the research has fallen as well. They can be helpful. Some people can't tolerate them. So I usually start slow, and I start with specific types of probiotics that have been used in clinical trials just to be shown to be helpful. So these are kind of the ones I use. Lactoprime is primarily lactobacillus, and it has no inulin and prebiotics in it, which also can be irritating to SIBO patients. And the BioGastric is Lactobacillus reuteri, which has been shown to increase gastric motility. And then Saccharomyces boulardii, which is a beneficial yeast, which has pretty much been shown to be helpful in everything. So I go with what the patient can tolerate with probiotics. Sure.
What's the difference between a prebiotic?
Sure. A prebiotic is usually a fiber-rich supplement that helps feed the good bacteria. So things like inulin, chicory root, Jerusalem artichoke, those are all things that help the good bacteria stay in its place. Probiotic is actually the bugs, or the strains of the bugs. So this is phase 1. Go ahead.
What's your opinion on taking prebiotics so that your natural flora grows versus, the levels of like these particular probiotics may not be natural to you and eventually die off?
Sure. So I think in not the case of, so his question was about prebiotics and their benefits and how to use them. Prebiotics and SIBO typically don't go together just because patients really can't tolerate them. For overall GI health, absolutely. Prebiotics. We love prebiotics. They help keep the good bacteria in your gut. They feed them. We want you to have high fiber. We want you to have prebiotics. In SIBO, it can be difficult.
For those probiotics, are you
Sure.
saying you recommend only taking those type? Because sometimes you get like a blend, like I buy Garden of Life.
Sure.
It seems to have like a longer
Everything, yeah. And I think there's benefits to that as well. I typically try and recommend specific strains just because I know they've been studied with SIBO and I've used them clinically and have good experience with them. Phase 2. So prevent and repair. So the thing about small intestinal bacterial overgrowth is there's about a 20 to 30% relapse rate, which can sound discouraging. But I also like to remind my patients that this is in the general population. So this is the, typical patient that might go back to eating Wawa or Chick-fil-A immediately after finishing their Xifaxan treatment. I find that this patient population is living a different lifestyle and is taking some steps to help prevent. And you certainly need to take some steps to help prevent. So the reason why I spent that time on that super complicated slide about the MMC and the gastric motility and the gastric pH is because all the things that we talk about in prevention, we're addressing those so that the underlying cause that may have triggered your SIBO is being worked on so that it doesn't happen again. So the first thing that I have all patients start immediately following within a week of stopping any protocol, whether it's the herbals, the antibiotics, or the elemental diet, is a prokinetic. And a prokinetic is an agent that stimulates the MMC. I got this, now I got this. To contract and to flush. There are herbals, there are prescriptions. I use both. Iberogast is probably my favorite herbal prokinetic. It is a blend of 9 herbs. It was formulated in Germany a long time ago, and it has things like chamomile, lemon balm, peppermint, licorice root, and it tastes terrible. Although some people really like it. It's very bitter. It comes in a tincture, and you put it in a little water, And for a prokinetic effect, I have you take about 30 to 60 drops at bedtime. You can also use it to help with symptoms. I have patients take it before meals to help with digestion or after meals to help with bloating. It's kind of magical. It's really good for reflux.
Magical.
It is
Good
magical. It's really good for reflux symptoms as well. Mm-hmm.
Should you wait till you're done your antibiotics to start?
No, you can take Iberogast right away, and oftentimes I have patients do that because they feel bad. You know, if you're bloating with each meal, and you're being on 6 weeks of herbs, like you want some relief, and Iberogast helps with that bloating tremendously. Yes. The other herb that I sometimes use as a prokinetic is Modal Pro, and it's by Pure Encapsulations, and it's ginger, 5-HTP, it has a little B6 in it, and you would take 3 capsules of that at bedtime, and that helps stimulate the MMC as well. There are prescription prokinetics. Low-dose naltrexone is probably the one I use the most. This is a compounded medication. Naltrexone is FDA approved and used in conventional medicine at a dose of like 50 to 100 milligrams in opioid addiction. However, at 1.5 to 4.5 milligrams, it's really good as a prokinetic. It also has been shown to be immensely beneficial for Crohn's, ulcerative colitis, Hashimoto's, chronic fatigue, and fibromyalgia. And a lot of my patients not only have SIBO, but have chronic fatigue, fibromyalgia, IBD. They all kind of can sometimes go together. And how it works, we're not quite sure yet. It stimulates the immune system in just the right way that it helps reduce inflammation. The other thing about LDN that I really like is it has a very, very low side effect profile. The only real side effect is disturbed sleep, and it lasts about 2 weeks. So when we think about drugs that are used for Crohn's and ulcerative colitis, they're biologics. They alter our immune system. They have some consequences. They're life-saving for a lot of people, but they also increase your risk of cancer and other things. So having something as a tool here, I think, is really, really unique. Yes.
Can it only be put in water?
No, you can mix it with anything.
Okay.
Yeah. It is bitter. You might want to mix it.
You said it had chamomile, peppermint.
Yep. Lemon balm and a couple other herbs that I have trouble pronouncing, so I didn't include them. Yes.
You mentioned the range for the Iberogast.
Sure.
How
Yeah.
do you know how much like you need or
Yeah. So with meals, I usually say 15 to 20 and start with 15. See how it feels. If you feel like you can use a little more support, go up to 20. At nighttime, I usually do 30. But if a patient, relapses or is experiencing more symptoms, I'll increase it. I usually start around 30. I always want to get on the lowest dose possible and go from there. The other prescription, there's a couple other prescription prokinetics that fall around the same category. They all are serotonin agonists. A lot of them are pulled from the U.S. market. Resolor is not available in the U.S. You can get it through Canada. I only have a couple patients on this. It's a pretty good prokinetic, but it's a pain in the butt to get. You have to order it from a Canadian pharmacy. It takes a couple weeks. So there's some issues there. There can be a little diarrhea with it as well.
Why would they do that as opposed to, like, what's the...
If someone had the question was why choose a prescription over an herbal? I wouldn't unless the herbal wasn't doing the job. LDN, I will suggest for patients that do have an autoimmune issue or do have chronic fatigue, because it works on 2 ways. It's going to help with their symptoms, but it's also going to help work as prokinetic. So I use that a lot quicker than I would a Resolor. So that's the prokinetic piece. There are also some things you can do lifestyle-wise to help stimulate the MMC. So one is meal spacing. So this might not work for everybody. Some patients that might be diabetic or that have adrenal issues or have low blood sugar, they may not be able to go 3 to 4 hours in between meals. But this MMC contracts when our stomach is empty. So we want to allow that as much as possible. So meal spacing 3 to 4 hours apart, breakfast, lunch, dinner, no snacking, and then fasting at least 12 hours between dinner and breakfast. That's really where we get the most of this flushing. The The other dietary intervention I recommend post-treatment typically is a low FODMAP, SED type of diet. There are probably 5 or 6 different diets that are associated with SIBO. I don't care which one you do. I usually just say pick one and then modify it to you. So you pick one, you stick with it for a couple of weeks, and then you start adding food back in and you see how you tolerate it. And I don't want my patients on a low FODMAP diet long term. Low FODMAP, SED, these are low fiber diets. Our body needs fiber, especially our large intestine, so the goal is not for people to be on these long term. So usually I say about 2 to 3 months post, treatment or post feeling better or post negative test, and then slowly start to add back in foods and see how you tolerate it. And oftentimes, I'll have patients meet with Rachel, who's our nutritionist, to help with this because these diets are not, they're not intuitive. They're very confusing, and sometimes it's nice to have support. For the low FODMAP, it's apples are really high, which they're healthy foods that are on there, so that can be hard. The other thing I like to do is support motility. So it's important to have bowel movements. Things will definitely get backed up if you're not having bowel movements. So things that we use most commonly in our office for that are magnesium. Most of us are deficient in magnesium. About 40% of the U.S. population is deficient in magnesium. It's an important nutrient. Not only is it an electrolyte, one of our top most important electrolytes, it's our body's natural relaxer. So it's helpful for anxiety, sleep, relaxing our bowels so we have a bowel movement, muscle pain, and then it plays a big role in our detoxification and supporting our liver. So magnesium's great. I usually have people take it at bedtime and titrate their dose up so that they're having a daily bowel movement. And then sometimes if they're on high doses of magnesium and still not having a great bowel movement or a daily bowel movement, we'll add in vitamin C. You can even do a vitamin C flush where you use vitamin C almost like a laxative as a cleanse. So vitamin C and high doses can help you go to the bathroom as well. Great question. The question was what form of magnesium. I typically use magnesium glycinate because it's the most bioavailable. Also, I find some patients get some cramping with citrate. It's a little rough on the stomach. So we typically use glycinate. And you can find that in a powder and a liquid as well, which can be helpful because sometimes you're titrating up, 600-800 milligrams.
Is that like calm?
Calm is magnesium oxide, and I think it has a little citrate in it. It's not glycinate, but yes, it has the same kind of effect. Yeah. If you can tolerate calm, that works. And that is a powder. Mm-hmm.
Is there a vitamin C liquid that you would recommend for teens?
Vitamin C liquid. There's a lot of chewables, I know.
There's also a vitamin C powder which you can turn into a liquid, and I know that that's available.
Yeah.
We don't have that in the clinic, but that's available online.
Mm-hmm. I'm not sure the brand of that, though.
No, I'd have to look for the brand of that.
Yeah.
It's a little off topic, but you're
Sure.
dealing with the nutrition.
Yeah.
It deals with electrolytes and muscle cramps.
Mm-hmm.
Pickle juice. Have you ever heard of that?
Yeah. So that's high in sodium and potassium. Yep.
Now, does that also contain magnesium, and does that actually work?
I don't think it contains
It doesn't
magnesium.
contain magnesium.
No.
Okay,
But-
it helps with muscle cramps and dehydration, so that is true.
So if your muscle cramps are from dehydration, it could, theoretically, because it has a lot of sodium and potassium.
All right, so you need to be careful because it's advertised for athletes, but then a lot of pseudo nutritionists are recommending it for
Other things.
Yeah.
Pickle juice.
Also, people are using it for hangovers.
That's definitely dehydration.
Because you get really dehydrated.
Yeah,
when you
yeah.
do alcohol.
Oh, is it?
Depends. Yeah, I mean, I would if you have SIBO, I'd be careful with pickles just because they are fermented and it's kind of on the FODMAP list there.
So I'm sorry, I missed that last part.
So with patients that have SIBO, you want to avoid fermentable foods. The low FODMAP diet is a low fermentable carbohydrate diet. So pickles are fermented cucumbers. Most of the pickles you find in a jar on the shelf they don't have any live bacteria in them anymore unless you're buying, bubbies that are refrigerated or you're making them yourself. But typically we advise avoiding fermented foods.
Like no miso, no kombucha.
During the active phase, I say no. As we transition out of this and you're healed and we're repairing, absolutely start to add things back in because they're very, very good. But in the kind of active phase, it can be irritating. I know you have a question. I see it on your face.
Just with cultured vegetables
Yep.
and like coconut kefir, I know that
Yep.
greatly helps me. And now, I don't know, is that included in not, you recommend not having that during?
So usually I have people decrease or stop probiotic foods and probiotic supplements during SIBO to see if it's affecting them. If you stop it and your symptoms are the same, then you want to add it back in and see how you tolerate. I'm okay with that. But typically it can be irritating. After treatment, absolutely. Those are great things to have in your diet. And I'd love a recipe if you had one for coconut kefir. And exactly, adding is, yes, that's a really good point, Cami, is to start slow and see what your body can tolerate. We talked about supporting motility with that visceral massage. And the other piece is support digestion. So oftentimes our body is not making enough digestive enzymes or bile to help break down our food. So taking digestive enzymes with meals, bitters, iberic acid is a bitter, but there's certainly other bitters, Swedish bitters out there. You can make your own bitters. It's very ambitious. Apple cider vinegar and water before meals can help increase your own production of bile and digestive enzymes. Lemon juice and water can as well. Certain teas, peppermint can too. And then mindful eating. I am very guilty of this. You know, dinner for me is over the counter, eating toddler scraps and telling my daughter to sit down. So I'm not exactly sitting and taking deep breaths and allowing blood flow to get to my digestive organs. I'm thinking about how I should be doing that. So I don't know if that's mindful eating, but it's not exactly happening. So I think we're all guilty, or I know I'm guilty of that. So actually sitting down and taking a couple deep breaths and being present goes a really, really long way. So here's Dr. Tetlow, so diligently working on Jane's plan. So this is just kind of a sample of what all the stuff I just talked about might look like for Jane. The first thing I would do is treat her SIBO, and I used 6 weeks of Canibacter AR and BR. I had her take digestive enzymes with all her meals because her stool study showed she wasn't digesting fats. I had her add glutamine, which we'll talk about in a little bit, to help support her leaky gut. And then I had her replete her nutrients that she was low in. B12, I told her to take sublingually so that it's absorbed in her mouth and not her stomach, and vitamin D. After 6 weeks, Jane felt 60-70% better, but not great. So we did another 4 weeks of neem and allicin. We stopped the Canibacter, and then we added the Biofilm Disrupter, the NAC. We repeated the test after that. It was negative, and then we moved on to that repair phase, and she took iberic acid, 30 drops at bedtime, did a low FODMAP diet, and then she continued on the digestive support. This easily could be a picture of Anne-Marie or me, too. We both all work so diligently on Prenlands here. Sure. Yeah. Sure.
Is there any particular brand that you
Yes.
like to use, or any particular enzyme that you think is better than
Yes.
another?
I have a whole slide about it.
Oh, okay.
And I was going to slip ahead, but I realized when I do that, it loses my recording. So we'll get to it in just a minute. Thank you. Yes.
Relative to the diet choices.
Sure.
My son does a low FODMAP
Yep.
diet now. Is there ever an instance where you would recommend no dairy?
Yeah, most of the low FODMAP is low in dairy. You have some of the 24-hour yogurt or the cottage cheese type situation. Yes, oftentimes with patients with IBS symptoms, I say try eliminating dairy for 2 weeks and see if it makes a difference.
And 2 weeks would
I say about 2 weeks with dairy and see how you feel. It's not like gluten. Gluten, I say 4 weeks. But dairy, about 2 weeks, you can see a difference.
And if you don't have gut symptoms,
Mm-hmm.
what other relief or changes might you feel with either eliminating gluten and or dairy?
Dairy. The question was, if besides GI symptoms, what else might you experience if you eliminate dairy or gluten? Dairy, I often see a correlation with mucus, so chronic sinusitis, chronic cough, asthma, things like that. I also see association with skin and acne and dairy intolerance. I am a fan of dairy if you can tolerate it. You know, whole milk, fermented, local dairy has good health benefits.
Like non-pasteurized.
Yep, that can, yep. However, 60% of the population cannot tolerate dairy. So it's a very individual thing. And if you think you have any of those things like chronic sinusitis, asthma, I would say try and avoid it.
What about like eczema? Is that thrown in?
That throws in there too, yep.
Rash would be the only
Yep.
other area I would
Yep.
mention.
Gluten, any patient that we have, and I think this is both you and Anne-Marie as well, that has autoimmune disease, particularly involving the thyroid, we always recommend gluten-free. Gluten is one of those molecules, glandulin in particular, which is the protein that's broken down with gluten, that is extremely irritating. And when you potentially have intestinal permeability or a disruption in the barrier here, and it can get into your immune system, it looks a lot like thyroid antibody, and it can trigger something called molecular mimicry, so it can actually make thyroid antibodies a lot higher. And I've seen patient antibodies go down like in half with just removing gluten. So with most autoimmune disease, we say to avoid gluten. And you'd have to be not having gluten for about 30 days for your body to stop producing antibodies to it. Yes?
So my GI doctor, she put me on Xifaxan. I
Yeah.
took it. because
Yeah.
I had SIBO and nothing.
Sure.
And then she's like, right when you're done, take probiotics.
Yeah.
And I do notice a difference when I don't take my own homemade yogurt or probiotics.
Yeah.
I feel worse.
Sure.
And I see that you don't have it up there. Is
Yeah.
it because you're like, you wait till?
Oh, it's only because I covered it on the other slide.
Oh, okay.
Yeah, but yes, some patients I will, yes, I use probiotics. And I use it slow because I have some people that just can't tolerate it. Yeah. Sure.
In reference to dairy,
Yeah.
where do you fall as far as where yogurt falls with dairy? So I know
Yeah.
yogurt can be
Yeah.
really good.
Yeah.
But, so I have a
Yeah.
son who has asthma. And
Sure.
So hearing like the dairy part of it, and he loves yogurt.
Yeah.
Like, yogurt, cheese, I mean, everything that he probably shouldn't be
Right.
eating, right? So
Yeah.
where does that kind of
Sure. The great question. It was about yogurt and the benefits of yogurt and how it relates to asthma. I think of all dairy, yogurt, kefir, things that are fermented dairy are your best choices. There are also other forms now. I think we live in a world where we have a lot of choices, which is great. So the coconut yogurts, the almond milk yogurts, they're all fermented and they're pretty good. My 16-month-old doesn't do dairy because she gets all the runny nose stuff. And she will do the coconut and she'll do the dairy and she'll drink the almond milk and the cashew milk. And they're actually pretty easy to make yourself. And there's lots of really good recipes online as well. Yeah, but of all choices, they're the best, the fermented dairies. Sure.
Is glutamine what's in bone broth?
That's collagen.
Collagen. Okay, I was curious about bone broth.
Yep.
You recommend that.
Yep. And I think bone broth is really key for healing a leaky gut. I don't see it as much in SIBO. I think it's nourishing overall, but particularly with intestinal permeability, bone broth is really rich in collagen, which helps bind those tight junctions back together.
sometimes
Yeah.
goat's milk
Yes, that's a good point. Goat's milk can also, and goat's milk yogurt can be better tolerated.
and cheese too. There's a lot of good cheeses.
Yes.
Milk itself is strong,
Yeah.
but there's a lot of good cheeses.
Yeah.
These are fantastic questions. I'm just noticing.
I mean, we have a lot
that
left.
There's probably a third left or a half left to go. So let's come back to the presentation.
Okay.
And if we can just save questions to the end, that would be wonderful.
Thanks. Thanks, Dr. Tola. So this is transitioning a little bit away from SIBO and talking about leaky gut. It's a 5R approach that we use in the clinic. Remove, repair, reinoculate. Remove, replace, reinoculate, repair, and rebalance. So remove is to treat the pathogens, the infections, or the overgrowth. So SIBO would be one of them. Treat or eliminate food allergies or sensitivities. So oftentimes I'll have people consider an elimination diet, which you remove the most common allergens, and then you reintroduce them one by one, and you see how your body responds. Or you can do a blood test for IgG, which lets you know if your immune system is making antibodies to certain foods. Other things that you want to try and remove that are irritating to your gut lining: alcohol, medications, things like NSAIDs, antibiotics, obviously, and then things like simple sugars and carbs, simple carbs, things that are kind of come from a package and like that, all irritating to the gut. So the first stage is to get rid of the bad guys, so kind of stop that inflammatory process. This is the digestive enzyme slide. The second is to give back the digestive enzymes so that your body can absorb all the things that it needs to heal. So we start making enzymes in our mouth. We make them in our mouth, our stomach, our small intestine, all the way through. So we like to recommend digestive enzymes that have a lot of these components. The one we use in the office, that's my favorite, if I have a favorite digestive enzyme, is Designs for Health. It's Digestimes. I like it because it has ox bile extract in it. It has betaine, HCl, and then it has a good combination of amylase, lipase, peptase. These are all things that break down fats, proteins, and products. So that's a good one to use. There's other ones that have that combination as well. And you don't just have to take a digestive enzyme. You could do something like iberogast, which helps support digestion, or the lemon juice, or the apple cider vinegar. All of those help your body break down the fats and proteins themselves. Sugars, we mostly absorb carbs mostly in our mouth. So that's why I keep saying fats and proteins. So this is the probiotic slide. So this is re-inoculate. So this is giving back the good bacteria or supporting the good bacteria you have in your gut. And the best way to do this, we use a lot of probiotics. I think they're immensely beneficial, but really it's the food choices that make the biggest impact on gut health. So probiotic foods and fiber. Fiber is the food for the probiotics. And when the good bacteria in your gut eat fiber, they secrete short-chain fatty acids, which is the food for the cells of your gut lining. So probiotic foods, I think we've talked through questions about these, raw apple cider vinegar, sauerkraut, kombucha, kimchi, beet kvass, organic plain yogurts are all good probiotic foods. Prebiotic foods are fuel for the good bacteria. They are non-digestible carbs. They help stimulate the growth of the good bacteria. And sources of these are dandelion greens, Jerusalem artichoke, garlic, cabbage, onion, leeks, asparagus. I know all your SIBO people are like, I can't eat that, I can't eat that, I can't eat that. Eventually, the goal is for you to eat that. Fiber, there's soluble and insoluble fiber. Soluble fiber slows down digestion, it lowers blood glucose, it helps balance blood sugar, it can lower your cholesterol levels, it makes you feel fuller, it absorbs water. Things like this are flaxseed, which you always want grounds and keep them in the fridge or freezer. Lentils, peas, chia seeds, berries, those are sources of soluble fiber. Insoluble fiber adds bulk to the stool, it promotes regular bowel movements, and it helps push out the toxins. Sources are grains, nuts, broccoli, cucumbers, carrots, green beans, zucchini. You can also take fiber supplements. Psyllium husk is a good one as well. Goal is somewhere between 30 and 50 grams of fiber a day. Most Americans get about 10. Do not go out and take 30 grams of fiber. If you've been eating 10, you will not be happy with me. Go slow. This is how we repair that lining. So as we discussed earlier, this lining regenerates every 7 days. So we have an opportunity every week to help with this lining. Some nutrients that are needed, D, A, C, and NAC are all help create the tight junction. Zinc glycinate, and zinc carnosine are really good. Omega-3 fish oil is helpful. L-glutamine is probably what we use in the clinic the most, and you need a good amount of this, about 5 grams, and you could take that up to 3 times a day. It comes in a powder. That really helps restore the gut lining.
5
grams. 5 grams. You can go up to about 15 to 20 grams a day. But I usually start with 5 grams once a day and see how people do. Curcumin, which is another anti-inflammatory herb, can be helpful. Collagen, whether it's in a collagen powder or in bone broth. Bone broth is super easy to make. I just save all my chicken parts, and when I have a lot, I put them in a big pot, cook it all day, and then freeze it. And then once a week I can pull it out and make soup or have it that way. No. Collagen, no. Do you eat any fish? Yeah, you can buy Vital Proteins has a marine-based collagen. It's a little expensive, but I don't think it has a taste. It dissolves as well. And then herbs. There are some herbs that are really healing. Things like licorice and aloe and marshmallow root are all very healing to the gut. Other things that are key pieces, getting exercise, mindful eating. When we sit and we pay attention and we're in a relaxed state when we eat, the blood is diverted to our gut so that we can digest. So that's key. Drinking enough fluids, and then healing foods like vegetables, fruits, which are high in antioxidants, and bone broths. Yes. Also, yeah, gelatin is also can be very helpful. I don't use it that often. Do you use gel? No. But yes, I've had patients use it and do quite well. And the literature is pretty good with gelatin and how it can be helpful. So the last R, the fifth R, is rebalance. So this is the importance of healthy lifestyle habits and stress management and how they really can affect your gut health. So sleep, exercise, managing stress, that lovely meditation we did before this presentation, practicing mindfulness, this all can help restore our gut health. This is all the things we talked about. Questions? I made it. Look at that. Thanks for coming.